Good evening, students. Good evening, everyone. Please confirm if the audio and video are fine. So today we are here for the MDS 360 degrees series oral surgery session. Today's topic is impactions. I will be covering this topic in two parts. So part 1 is today and part 2 will be taken next week. Thank you, Utkarsh. Thank you for confirming. So we will be covering this in two parts. All right. In today's part, I will be covering the indications of removal of impacted teeth, order of impactions, classification of impacted teeth, and in the next session we will be doing the radiographic assessment of impacted teeth, scoring, difficulty scoring of impacted teeth, and what are the steps for removal of an impacted teeth. So I've divided the session into two parts. Let us start. Now, what do you mean by an impacted tooth? So any tooth which has failed to erupt beyond its chronological age, even when its root formation is complete. Okay. So if the chronological age for eruption of a tooth has passed by, but the tooth has still not erupted, even though the root formation is complete, that is known as an impacted tooth. Let us go through the definition. It is defined as, I'll increase the thickness a little. It is defined as failure of a tooth to erupt into fully functional position against its antagonist beyond its chronological age of eruption, even when root formation is complete. Okay, so this is important. Chronological age of eruption, beyond chronological age of eruption, and when root formation is complete. These are your two most important aspects. Okay. Now let us see the order of impactions. The most commonly impacted tooth is mandibular third molars. This is the most commonly impacted tooth. Mandibular third molars, followed by maxillary third molars, followed by maxillary canine, followed by mandibular second premolar, followed by mandibular canine, followed by maxillary premolars, and followed by supernumerary teeth, and followed by maxillary incisors. So these are the least commonly impacted teeth, most commonly being mandibular molars. This is a question also which comes in your exam. Okay. Now, what are the indications for removal of impacted teeth? There are various scenarios where we need to undertake extraction of impacted teeth. Let us see what are the scenarios. The first and foremost very important one is pericoronitis. First, let us understand what is pericoronitis. So you must all have seen clinically also, when a tooth is partially erupted, part of it is covered by a soft tissue covering. All right. So the flap or the soft tissue covering which surrounds or covers a partially impacted tooth, that is known as the pericoronal tissue or pericoronal flap. Okay. Any inflammation of this surrounding tissue, the pericoronal tissue or pericoronal flap, is known as pericoronitis. I hope that is clear. Inflammation of pericoronal flap. What is pericoronal flap? The soft tissue covering or soft tissue surrounding a partially erupted, impacted tooth. Okay. So like I just explained, inflammation of pericornal flap around any partially erupted tooth. It is mostly seen with mandibular third molars. It is mostly seen with mandibular third molars. What is mostly seen with mandibular third molars? Pericoronitis. And it is the most common cause for mandibular third molar removal. Most common cause for mandibular third molar removal is pericoronitis. Now please understand the next point. Pericoronitis is more of an inflammatory component than a true infection. I'll just get this into frame. Yes, pericoronitis is more of an inflammation rather than a true infection. Please do not confuse, because all cases or maximum cases of pericoronitis are not associated with pus discharge. Only when it gets secondarily infected, there is pus discharge along with pericoronitis. But pericoronitis per se, most of the times, is just inflammation of the surrounding pericornal tissue and not a true infection. So pericoronitis is inflammatory component rather than a true infection. Why? Because pus discharge is not present. Pus discharge is not present. Okay. Now let's see what is the treatment of pericoronitis. Now whenever there is pericoronitis, that means there is acute inflammation present. We have to first take care of the acute inflammation before going for extraction or removal of pericornal flap. Now when there is pericoronitis, you can approach this in three ways. First of all, you have to get the acute phase under control. Second type of treatment that you can do is a operculectomy, that is removal of the soft tissue flap which is covering on the tooth or which is interfering between the occlusal surfaces of two antagonist teeth. And third one is removal of the third molar. Okay, let's see one by one. So first one is control of acute phase. How will you control the acute phase? Irrigation of pericornal flap, extraction of antagonist tooth, warm saline rinses, NSAIDs, antibiotics. So let's see one by one. You will ask the patient, you will teach the patient how to irrigate beneath the pericornal flap. What will happen? It will wash out all your food lodgement, it will relieve pressure, it will decrease inflammation. Alright. Extraction of antagonist tooth. So what might happen that when the opposite tooth constantly causes trauma to the pericornal flap, it will cause more and more inflammation over there. So the to take care of the pericoronitis, you can remove the opposing tooth. Okay, you can ask the patient to do warm saline rinses, which will help in getting the inflammation down. You can give NSAIDs to tackle pain and inflammation. And yes, if there are any systemic signs and symptoms present along with pericoronitis like fever, leukocytosis, then you can go in for antibiotics also. Alright, so you get, before taking up any surgical procedure, you tackle your or take care of your acute phase first. Okay, now the best or definitive treatment is third molar removal over operculectomy. Third molar removal. Why? Because Once you remove the third molar, there is no recurrence of pericoronitis. No recurrence of pericoronitis. That is why this is the best treatment. Operculectomy is removal of, I told you, operculectomy is removal of the pericoronal flap or pericoronal tissue which is surrounding the impacted tooth. You just remove the soft tissue in operculectomy. Okay, but the soft tissue tends to grow back again due to various factors. It can again cause inflammation and irritation to the patient. That's why even if you do an operculectomy, the chances of recurring pericoronitis are higher as compared to removal of third molar. So removal of third molar is the best treatment for pericoronitis. Okay. Now the second indication, dental caries involving impacted tooth or adjacent tooth or both. So if the impacted tooth has developed dental caries, or due to the position of the impacted tooth, if the second molar has developed dental caries, then you have to remove or extract the third molar or impacted tooth. Okay. Third is periodontitis in relation to impacted tooth. So if you can radiographically make out any bone loss in relation to impacted tooth, then also you have to remove the impacted tooth. Chronic cheek biting. In case there is a partially erupted tooth which is causing constant cheek biting to the patient, in that case also it is an indication for removal of impacted tooth. Resorption or damage to adjacent tooth. Okay, whether in the form of caries, whether resorption of adjacent tooth, in all such scenarios you will remove the cause which is your impacted tooth. The next indication is development of pathology in relation to the impacted tooth. If there is a dentagerous cyst or a tumor which is developing in relation to the impacted tooth, you have to remove the pathology as well as the impacted tooth. Okay. Orthodontic reasons. Suppose if your orthodontist or if the patient's orthodontist wants removal of impacted tooth for his tooth movements or due to space issues, then also you have to remove the impacted tooth. Okay. The next reason is orthognathic reason. So if a patient is planned for orthognathic surgery, okay, and you feel that your impacted tooth will fall in the line of osteotomy, either in the mandible or in the maxilla, then you have to remove your impacted tooth 6 to 12 months prior to surgery. Why this time gap? So that you can allow for healing. अगर orthognathic surgery planned है आज से 6 months बाद and you remove the impacted tooth today, so what will happen? Proper bone healing हो जाएगी in the duration of 6 to 12 months, and you can easily osteotomize your bones. So orthognathic reason, and this is a question (6 to 12 months prior to orthognathic surgery). The question. Okay. Prosthodontic reasons. So suppose if there is a edentulous patient, okay, who has undergone ridge resorption and now the impacted teeth are very much superficially placed, and the prosthodontist advises removal of impacted teeth because it is interfering with the construction of prosthesis. So in that cases also you will remove the impacted tooth. Okay. So prosthodontic reasons. Now there is one more reason why you remove an impacted tooth. There is something known as prophylactic odontectomy. Now, what is this? Prophylaxis, basic meaning of prophylaxis is prevention. Alright. Now, prophylactic odontectomy means that you are prophylactically removing a asymptomatic third molar so as to avoid any future problems or any future ill effects that it might cause. Alright. And when do you remove these third molars? You remove them in their developmental stages. Alright, you remove them in their developmental stages. So, prophylactic removal of asymptomatic third molars. This concept was advocated by a few clinicians, few authors, so that they thought that if we remove the third molars in its developmental stages, we can prevent its ill effects that might trouble the patient. Alright. So, prophylactic removal of asymptomatic third molars, advocated by some clinicians to avoid future ill effects of mandibular third molars. And when do we remove these third molars? In the developmental stages. Exactly, I'll tell you when. Okay. Now, the indications are to save the periodontium of second molar. Second molar is a functional tooth. In comparison to a third molar, it is important. So, to save the periodontium of a second molar, to avoid caries of second molar, and to avoid angle fractures, especially in persons with contact sports like boxing, rugby, or football. Let us understand this point. So, if a person is a contact sport player, what do you mean by contact sport? Where you have close contact with your opponents. You are in close range with your opponents, and injury to your face, the chances of injury to your facial region is high. For example, boxing, rugby, football. So, in such sports, there are chances of injury to the face. Now, what can happen if there is an impacted tooth, impacted third molar especially, it can cause weakening of the angle region of the mandible. Alright, thereby leading to its fracture during a impact. To avoid this from happening, especially in contact sports persons, we prophylactically remove third molars in its developmental stages. Please note, partially impacted mesoangular tooth are most commonly associated with mandibular angle fracture. Partially impacted mesoangular third molars. Okay, so this is important. This is your question point. Please make note of it. Okay. Now, this technique of removing the third molars prophylactically in its developmental stages is known as the Bowdler-Henry technique, also known as lateral trepanation technique. Alright, this is a technique for prophylactic odontectomy. It is removal of mandibular third molars during its developmental stages. And the ideal time, these teeth should be removed when roots are half to 2/3 formed. Please remember, there are various answers given at various places. So these teeth should only and only be removed when roots are half to 2/3 formed. Okay, this is important and this is been asked quite a few times. Now, why are these teeth which are in its developmental stages to be only removed when roots are half to 2/3 formed? Because if the roots are smaller or less than half formed, then what will happen if you go and try and remove these teeth? They will wobble in their socket. You will not have a purchase point to lift them out of the socket. They will keep rotating inside the socket whenever you apply any sort of instrument. That's why it is necessary that at least half root formation takes place. Now let us just understand quickly with an example what is lateral trephination technique. Okay. This is your third molar, all right, in the mandible. Okay. So what is lateral trephination technique is, you take a trephine burr, all right, and you do punch holes here in the buccal cortex. Okay. You join this and you remove this window of bone. So you basically are creating a window into the buccal cortex. Now once you have created a window in the buccal cortex, you can take your instrument and lift this. You can engage the tooth through this window in the buccal cortex and just lift it out from the socket. Alright, obviously you will give an incision occlusally. Okay, once you have reflected the soft tissue flap, you will create a buccal window and you will lift the tooth out of the socket. So this counteracts the issue of wobbling or rotating of tooth inside the extraction socket. Okay. So I hope all of you are there and paying attention to what I'm explaining. If there are any doubts, you can ask me in the live chat box. I'll answer all your doubts if you have any. Okay. Now, contraindications for removal of impacted teeth. There are certain generalized systemic contraindications which are nothing but if the patient is having any uncontrolled systemic diseases like diabetes mellitus, epilepsy, asthma, or unstable angina. So these conditions are a contraindication. The patient has to be referred to a physician and they will get these systemic conditions under control, and then you can go ahead with your extraction. The second contraindication is when third molars are deep seated but not symptomatic. So if there are deep seated third molars but are not causing any issues to the patient, you leave them alone. You don't touch them because trying to extract them or remove them may be more harmful than beneficial to the patient. And when third molars can serve good function. Alright, so if there is a partially ruptured third molar or a impacted third molar which is most likely to erupt and take its position into the oral cavity and help in good functioning of the dentition, then in such cases also you leave the third molars alone and you give them a chance to erupt into the oral cavity. Very good, Utkarsh. I'm glad you are still there and you can ask me if you have any doubts. Now coming to the classification of impacted third molars. Alright, we'll now see the classification. In this session, we'll do the classification. Next session, we'll do the radiographic assessment of third molars. So the first one is Winter's classification. Your Winter's classification is basically based on angulation of long axis of mandibular third molar in relation to mandibular second molars. So on basis of Winter's classification, the third molar was classified into mesioangular, vertical, horizontal, which was further divided into buccoangular and linguoangular, distoangular and inverted. Okay. Now let's see one by one. Let's suppose this is the second molar, and this is the third molar. Now let us draw the long axis. You draw the long axis of the 8 and you stretch beyond. This is going to go mesial to the long axis of the second molar. So this becomes mesioangular. Okay. Similarly, distoangular, that means the long axis of 8 will fall distal to the long axis of 7. Okay, this is distoangular. Okay, in vertical the long axis will be parallel. In inverted, the tooth will be inverted, that is the crown will be at the bottom and roots will be above. All right, I want to explain horizontal, and in horizontal also especially I want to explain buccoangular and linguoangular. But first let's draw horizontal. So here what will happen, the long axis will be 90 degrees to each other, if you can see. So this becomes your horizontal. Now I'll draw the occlusal picture. Okay, this is suppose the lingual cortex and this is the buccal cortex. Okay, let us suppose this is the occlusal view of crown of 7. Okay, let us suppose this is 7. Okay, and now the tooth is horizontally impacted, but the I'm showing the occlusal view. Okay, this is the occlusal view, please remember. So if you see the angulation, the crown is towards the buccal cortex. The crown is towards the buccal cortex. So this becomes a horizontal buccoangular impaction. Similarly, if the crown would be towards the lingual cortex, then it will become a horizontal linguoangular impaction. I hope that is clear to all of you. Now the second classification that we have over here is Pell and Gregory classification. This is a more specific classification because it takes various components into account. The first thing it takes into account is Ramus relation. All right, Ramus relation is basically according to the availability of space in the ramus. I'll tell you in detail for the eruption of the tooth. Okay, the second component of this Pell-Gregory classification is occlusal relationship. So how is the third molar occlusally placed in relation to the second molar? All right. The third one is angulation of third molar, which is similar as your Winter's classification, and D is the expected complications. We will be just looking at component A and B over here. They are the most important and many times asked in your exams. So students, please be thorough with your Pell-Gregory classification. It is very important. In the next class, when we see scoring of difficulty index, then also your Pell-Gregory classification, you have to be thorough with it. Only then you will be able to score your tooth. Okay. So let us start. The first thing, Ramus relation. How do we determine the Ramus relation? So when we are looking at Ramus relation, we see the distance between the distal, from the distal aspect of the second molar to the ascending border of Ramus. Alright, and we see if that space is sufficient to accommodate the mesodistal dimension of the third molar or not. Okay, so it is divided, the Ramus relation is divided into classes. Okay, class 1, when the space between the distal surface of mandibular second molar and anterior border of Ramus is sufficient to accommodate the mesodistal dimension of the third molar, and this is the easiest type of impaction. Let us see with the help of a diagram. I'm not drawing the roots over here so that you don't get confused. Okay. Okay. Now please carefully follow my pen. Distal surface of 7, second molar, ascending border of Ramus, this distance. Okay, let's consider this as A. Okay, and mesodistal dimension of third molar, let's consider this as B. Now distance A can easily accommodate distance B, so that means there is sufficient space in the Ramus available to accommodate the mesodistal dimension of the third molar. Alright, this is your class 1. I hope it is clear to all of you. Let's see class 2, when there is insufficient space. So students, just a tip for all of you, wherever you can remember things by diagrams, by pictographic memory, that means you have to spend less time in memorizing or mugging up things. So this is a tip to all of you. Please try to remember as many as things possible with help of diagrams, charts or tables. Your recall becomes easier, your retention becomes easier, and you have to put in less effort to memorize. Okay, now let's see class 2, which is your insufficient space. This is your 7. This is your 6. Okay. Suppose we have a bulbous third molar. Now the distance from the distal surface of 7 till anterior border of ramus, this is distance A, and your mesodistal dimension of 8 is greater than the space available between 7 and anterior border of ramus. Alright, so this becomes your class 2 or insufficient space. Okay, fine. Now let's see class 3. Class 3 is no space present, tooth is completely in ramus, and these type of impactions are the most difficult to perform. No space, tooth is completely in ramus. This is important. Tooth is completely in ramus, and this is most difficult. Again, let's remember this with the help of a nice diagram. Okay, now see carefully. Here you will see that the distal surface of 7 is almost confluent with the anterior border of ramus. There is no space. Alright, and this particular tooth is in ramus. So this becomes your class 3. Alright students, the next component is angulation, which is you already know with the help of Winter's classification. So please let me know if Pellin-Gregory classification is clear to all of you. Please let me know in the live chat box if you've understood Pellin-Gregory. In case you want me to repeat anything, please let me know. I'll wait for 2 minutes so that you all can tell me. Okay, very good, Utkarsh. Others, in case you are there with me still, please do let me know. Now the second component, occlusal relationship. Alright, we have just seen the ramus relation. Second is occlusal relationship. I'm sorry, we had not covered occlusal relationship till now. After that is your angulation and then your expected complications. Now, most important point that you all have to remember is occlusal level is marked by occlusal fossa and not the cusp tip. Please remember, whenever we are speaking in terms of occlusal level or impactions, the occlusal level is always marked by the occlusal fossa and not the cusp tips. Okay. Now let's quickly go through. So occlusal relationship is divided into position A, position B, and position C. Position A is when the highest point of impacted third molar is either at or above the occlusal line, and this is the easiest. Okay. Position B is when the highest point of impacted third molar is present above the level of cervical line but below the occlusal line. Okay. Position C is below the occlusal line and cervical line both. Most difficult deep seated impaction. Position A, position B, position C. Ramus relation was class 1, class 2, class 3. Occlusal relationship is position A, position B, position C. Learn it here with me in the session. Now let us see. Again, I'll draw a diagram so that you all can remember easily and you don't have to mug up the definitions. Okay. Now, let's draw our impacted teeth. I'm drawing the 3 different positions which are possible. All right. Okay, let's first draw the occlusal plane. So from the occlusal fossa of 6 and 7, this is your occlusal line. I'll just move this a little. With green, we will draw the cervical line. Okay. Now, please follow my pen. I'm drawing a purple dot on each. So this highest point of the impacted tooth is present above the occlusal line. So this becomes position A. Okay. Let me choose a different color. Let's choose red. In this one, second one, the highest point of the impacted tooth is present above the cervical line but below the occlusal line. So this becomes position B. Okay. Here, the highest point of the impacted tooth is present below the occlusal line and cervical line. So this becomes position C. Okay. So I hope you all will not forget this now. The diagram has made it clear. Please remember the diagram. It will be very easy for you to recall in your exams. And if you please notice position C, it is present below the occlusal line and below the cervical line. So it is a deep seated impaction. You will require a lot of bone removal to remove this tooth. Hence, it is the most difficult to remove. Okay. Now the third is angulation of third molar, which is nothing but your Winter's classification. And the fourth component of Pell and Gregory is expected complications. We will not go into the details, just remember. Okay. The next classification of impaction is based on type of impaction. So this is very, very simple. Soft tissue impaction, partial bony impaction, and total bony impaction. So what do you mean by soft tissue impaction? When the especially the crown portion of the tooth is present in the soft tissue. Partial bony, that means it is partly covered by bone and partly covered by soft tissue. And total bony means when the tooth is completely present within the bone. All right. With this, we end today's session. Please let me know in the comments section if you have any doubts. And this is your schedule for the upcoming days. Please give us a thumbs up if you're liking our lectures. Share these lectures with your friends. Subscribe to the DAMS YouTube channel. And if you have any queries after this, even after the session gets over, you can leave us your queries in the comment section. We will get back to you and answer your queries. So just give me a minute. If there are any doubts, you can ask me in the comment section. Yes, Utkarsh? What is your question? Yes, for all your dental subjects, we will be covering almost all the major topics. I can assure you this. We'll be covering the major, most important topics. And we will try to cover almost the entire syllabus till your exams. You can also enroll with us. This is the number given over here. If anyone is interested, we have more material available on the app and on our groups. You can follow our groups. All right. So thank you for joining us, students. Thank you, Utkarsh. We look forward to your presence over here. Thank you, students. Thank you for joining in. Good night.